Before we begin the webinar, I just want to run through a couple of housekeeping items. If you're experiencing any technical issues during the webinar, please write them in the chat box at the bottom of your screen, and I'll be happy to assist. Everyone on the line has been muted except for the presenter to keep background noise down. If you have any questions, please use the chat box and they will be addressed by today's speaker. We'll be circulating a survey following the webinar to obtain feedback, so we ask that everyone take a couple of minutes to fill it out. Thank you again, and I will now hand it over to Pavitra Paul, today's moderator and convener of the iHEA Health Systems Efficiency Special Interest Group, who will be introducing our speaker. Pavitra, I think you might be on mute. Are you able to hear me?
Hear me?
Yes, I hear you.
Yep.
Oh, okay. So Agnès helps the national governments, particularly in Eastern Europe and Central Asia. She had spent about 4 years' time in OECD to prepare this report, where she has found that almost 20% of the health system's cost can be saved, which is getting spent because of unavoidable expenditure. So she will share with us her study, and please feel free to raise the questions. Purpose of this webinar is two-way interaction so that our learning can become relevant in the country, in the situation where we work for. I welcome Agnès Couffinhal to take this floor.
Thank you. I'm going to put the video for at least a second so you can see I'm a real human being. I might cut it off afterwards. And more importantly, I'm going to try to share the screen. I hope this works. Zoom, give me a second. Could someone, is the Pavitra?
Yep, it looks perfect.
Okay, thank you very much. So I want to start by thanking Pavitra and Bruno for inviting me to present at this webinar. I also want to acknowledge the fact that although only my name is on this slide, this is actually the product of a large group. It's collective work which was carried out by the OECD. I don't work at the OECD anymore. I was there on leave of absence from the World Bank, and I'm back at the bank. But today I'm wearing my OECD hat, and this is why you see an OECD slide background. So the work I'm going to present today is actually a report I'm going to give you an overview of, and I think it might be useful for you to understand how this came about. So the ministers of health of the OECD meet every about 5 or 6 years to discuss, big issues that they're struggling with, and also set directions for the OECD work going forward. And when this last meeting took place, they requested that 2 background reports be produced, one on new technologies and the other one on wasteful spending on health. And I was lucky enough to be picked to manage that work. So this report, the audience of this report is primarily policymakers. It was made for policymakers, and so it's not academic it was not an academic undertaking, although I do hope that the rigor, we injected enough rigor to satisfy academics when they need it. So during my presentation today, I'm going to start by explaining, why we think, which we need to talk about waste and how we defined it. We also created a taxonomy, which I'm going to introduce, which categorizes waste in 3 main categories. One is wasteful, medical care, second is operational waste, and the third, governance-related waste. And I'm going to address these three in turns, and I'm going to leave you with some parting thoughts. Maybe at the end of the introduction, since it's perhaps the more conceptual, I'll take a breath and ask if you have any questions. So I think you've been encouraged to send them by email or by chat to Pavitra, and I encourage you to do this. So, getting started. I know we're working around the world, and so for some of you, I hope this will wake you up if you're having a morning coffee. For those who are already thinking about what they're going to do tonight to celebrate the weekend, I hope this will keep you interested. Perhaps you might be aware, but adverse events probably occurs in 1 in 10 hospitalizations. They account for, on average, 15% of hospital costs, and depending on the studies and the context, it has, studies show that up to 70% of them could be avoided. Now, you might think that within a country, the procedures, the rates at which some procedures are performed is roughly even, but it is absolutely not the case. And there are large within country variations in the rates of procedures which are undertaken, up to 3 times for cardiac procedures, up to 5 times for knee replacement across geographic areas within a country, which means that certainly some places could be underserved, but there's also some places where these surgery may not be as necessary and may be in fact unwarranted. Sorry. Now, there's no standard way to account for inappropriate emergency departments, but this is a concern many countries have. Do people show up to the emergency room for the right reasons? And many countries have set up systems to try to capture inappropriate emergency visits. And in these countries, and of course these are different ways of measuring, but at least 10% and maybe up to more than half of emergency visits, department visits, could be inappropriate. The share of generics in reimbursed drugs varies across countries, OECD countries, between 10% and 80%. If you look at a country, in this case it was the UK, there's an atlas in variation of prices paid by hospitals, and for the most basic disposable, which is a wristband with the name of the patient, there can be an up to 2-fold variation in the price hospitals can pay. Administrative expenditure across healthcare systems vary more than 6-fold, and yet there's no obvious correlation with performance. Loss to fraud and corruption, or errors, fraud and errors, may average to 6% of payments for healthcare services. So, all in all, up to 1/5 of health spending in OECD countries is at best ineffective and at worst wasteful. This is our assessment. Now, you will notice that we didn't say 20%, and we said up to 1/5. And we were very nervous when we actually put out this number, and I'll tell you about a bit how this came about. But when we put it out, we said up to 1/5, and we were really nervous about the reaction we would get. And the typical one we got was, "Oh, really? No, you're probably underestimating this." Now, this number comes from, there are very few studies. So all these examples, these numbers that I've given before, example of wasteful spending, you can see that it occurs everywhere, and it takes many different forms. And so part of the issue, this makes it very difficult to actually measure wasteful spending in any given system. Now, some people have attempted this, and we have a number of studies, and they all come, between certainly 20% is on the lower end, but we also have studies that look at specific subsystems and so on. And so all in all, this is the up to 1/5 of health spending doesn't come from, it's not an OECD estimate, it's the best OECD guesstimate. Let me be perfectly honest about this. Now, what do we mean by waste? We try to come up in the context of the report with a very pragmatic definition. Waste consists mainly of 2 things. First of all, services and processes which are either harmful or do not deliver benefits. And secondly, costs which could be avoided by replacing them with cheaper alternatives with identical or better benefits. I forgot to set my time stopwatch, so I don't want to keep you too long, so I've just done that. Now, this suggests two very simple principles for dealing with waste. First of all, you stop doing the things that don't bring value. And second, you swap when equivalent but less pricey alternatives exist. Now, if you want to sign off now, this is essentially what the report says. I'm going to give you a slightly longer version, but this is the elevator version of it. Now, the way we went about this is we looked at whatever had been published that had the word waste or and so on, and we put everything on the board, and we tried to organize this a little bit and come up with a taxonomy. And we found that the best thing we could do was simply using the two following dimensions. One is, where does waste occur and who is responsible? The location. And we identified 4 key levels: the level of the patient, the clinician, the manager, and the regulator, going obviously from the very micro to the macro. And the second dimension we use to organize this taxonomy is the behavioral root causes. So in our view, waste occurs for 4 reasons. Waste occurs because people don't know better. So this is imperfect knowledge, cognitive biases. Waste occurs because people can't do better. So you know what would be right, but it's just the way the system is organized and managed, you just can't do it. The waste occurs because people stand to lose by doing better. So this is when the incentives are misaligned with the system's goals. And finally, waste occurs because, well, people are doing it on purpose. And this, we'll come back to this, that it's mostly fraud and corruption. So we have 4 different behavioral root causes that we identified. And of course, things are not easily clear cut. I mean, if you talk about, fraud and abuse, of course, you might think that people, you might suspect that there is an intention to deceive, but you could argue, it's simply the incentives are not well aligned. And of course, wherever you suspect might say that, oh, it was just, an error. I just didn't know that it was, it was a problem or it was not allowed. Now, if we put these 2 dimensions in a simple table, on the vertical axis you have the different kinds of perpetrators or actors, and then on the horizontal side you have the drivers. Some of which are clearly intentional and some unintentional, and the others which are deliberate. And now I'm going to go through the different types of waste and the groupings that we came up with. First one is preventable adverse events. Now, preventable adverse events are, the result of errors and suboptimal decisions, but also poor organization. The second type is ineffective and inappropriate low-value care. So this could be suboptimal decisions as well and organizations, but also incentives. So you're performing this surgery again and again because this is what you were taught and you haven't really updated your knowledge, but also you're getting paid every time you do it. So incentives certainly come into play more than they do for preventable adverse events, for instance. So now, the simple duplication of services. This patient received a test, was tested yesterday, but the information was not transmitted. Today he's in the hospital. We don't have the results, so we have to do it again. So that's a simple duplication of services, and it mostly comes down to poor organization. So all these types of wasteful spending we call wasteful clinical care, and they mostly occur, at the bedside between the patient and the clinician. The second type of wasteful spending is really at a higher level. It's discarding unused inputs, drugs that you've purchased or you've prescribed and the patient has bought but they're not using. Paying an excessive price, and this is, this fits, probably to the economists a bit. It sounds a bit more familiar. Or overusing high-cost inputs, and this is what we call operational waste. The third and last category, it's at at a higher level. It's got to do with the management and the regulation of the system, and it's really ineffective administrative expenditure. The final category is not so much defined by where it takes place, because it can take place everywhere, but more by the intention. So it's what we call, it's fraud and corruption, essentially, wasting with intention. And these two we group under the category of what we call governance-related waste. So this is our bidimensional taxonomy. A simpler, a more easy way of thinking about it might be this one, and it corresponds to the same, the same examples I gave, but basically waste occurs when first, patients do not receive the right care, so this is wasteful clinical care. Benefits could be obtained with fewer resources, that's more operational waste, and when resources are unnecessarily taken away from patient care, and this is governance related waste. I'm going to stop here. This is the end of my introduction, and ask you if there are any questions that you received, burning questions, Pavitra. Five, 4, 3, 2, 1. Are you hearing me? Are you hearing me?
Yes, I hear.
Okay, good. Thank you. The resounding silence was not a sign that I had been disconnected for the last 10 minutes.
No, we can hear you.
Okay, thank you. I prefer that. Let me go back to sharing the screen, sorry. Okay, so wasteful clinical care. So this is the most recent data from the OECD. In fact, it's not published, and I got it last night. This is an example of an adverse event. It's pulmonary embolism or deep vein thrombosis in hip and knee surgeries, the data from 2007. And so I want you to take a look at this graph. I mean, first, from the message, the key message I want to get through to you here is, whether they're reported or not, adverse events cost a lot of money. And they do occur. This is an example. I think I would like to take this opportunity, because I'll come back to this, to invite you to think about these data. Now, the OECD is really at the forefront of collecting data on comparable data across countries on these issues. And I think it's important to understand that the ranking is not just a ranking about the quality of the healthcare system. I think there is something which is equally, if not more important, is the ability of countries to actually create a culture in which it is okay to report a medical error or to report an adverse event. And so when you look at this ranking, I don't necessarily want you to think that getting a surgery in Poland and Lithuania is much, much safer than in the United States or Australia. It's really, I think it's a combination of two things, and I'll come back to this. Now, about low value care, I mean, I'm going to take an example which is very simple and easy to understand. I mean, so there are discussions about the rate at which C-sections should be performed, for, when there are deliveries. The WHO came up with a number of 15%, or on that graph it would be 150. Some argue that it could be higher. But on this graph, what I've done is I've represented EU countries, or countries of Europe rather, countries of Europe, and on the horizontal axis is the rate at which C-sections are performed, and on the vertical axis, the rate of growth of this rate between 2006 and 2016. And you can see that the EU, on average in the EU, I think about 270 out of 1,000, so maybe twice as high as might be strictly medically necessary. And then the rate of growth, the number of C-sections still increases at, close to 2% a year. But you can also see huge variation across countries. And there are countries like, the Netherlands and Nordic countries are good at this in that they have, fairly low C-section rates and fairly low growth of rates. France as well. So it's partly a culture, but it's also in France. In the case of France, there's been a lot of efforts over time to try to curb what was perceived as an undue increase in the rate of C-section. On the other hand, if you look at the Poland, Bulgaria, and Romania, the figures are rather frightening. And these are not the highest C-section rates in the world, by the way. I think Brazil gets the palm for this one. Another example I wanted to give, because I think it's critical for many reasons. This is the result of a literature analysis of in different subsectors, studies which in different subsectors try to assess the percentage of antimicrobial prescriptions which may be inappropriate. So each bar represents the range of in this proportion in different domains. So for ambulatory care, they were between, in 4 studies, they were between 4 and 70% they were deemed inappropriate. If you look at general practice on the right, they were, the studies show that, almost in practically all studies, more often than not, so in more than 50% of the cases, the prescriptions of antibiotics were inappropriate. Now, if we go back to wasteful spending, the issue here is not the direct cost so much as the indirect cost, because antimicrobial are not always very expensive, especially in medical, in general practice. But of course, the indirect costs, which could be, which are brought about by antimicrobial resistance, and then also adverse events related to antimicrobials are really the problem here. Now, wasteful clinical care, what can we do about it? The first finding, or the first thing that we found, is that we really need to work more on information systems if we want to better understand wasteful clinical care. So you need more robust information systems to identify low-value care. There's about 10 countries of the OECD that have issued atlases of variation in care. Of course, the forefather for this was the Dartmouth Atlas. But the problem remains that in many information systems are administrative, and they use for claims management. And in those, you may know what is done, but you rarely, or you don't always know why it is being done. So an example is imaging for lower back pain. Imaging for lower back pain is considered low value care. It's not necessary, except in certain specific cases. But if you see the volume of imaging for low back pain, imaging for lower back, you don't know why it was prescribed, and therefore it's very difficult to have a dialogue with whoever prescribed, because you don't know for what it was prescribed specifically. So we need much more, much more information, rich information systems. When it comes to adverse events, I was talking about this earlier, but what really matters is to have reporting systems which are, in which everybody trusts that the reporting will actually be used to learn from the mistakes and trying to find solutions to them rather than for punishment. New Zealand, and it wasn't on the graph earlier, but they do actually report very low values. But New Zealand is particularly well known for having set up a culture where reporting adverse events is doing well. And it's also not just in hospitals, because even countries which are advanced, fairly advanced, usually limit reporting of adverse events to hospital care, whereas in New Zealand it goes beyond this. The third lesson we learn, I mean, when it comes to information in this to tackle wasteful clinical care, is that it's increasingly recognized as important to actually account for patients' views on what constitutes value. So this is the whole PROMS and PREMS agenda, patient-related related outcome and experience measures. The clinical, if a patient doesn't die because of surgery, it's very good, it's preferable, but it doesn't mean that the surgery was of value. It may not change anything. In fact, they may be worse off than if they hadn't had the surgery and you had chosen a less, interventionist type of care. So, and this information can only be put to light if you actually ask patients about how they feel and what matters to them. So when it comes to this, England is seen as a leader among OECD countries. If you go to the website of a hospital in the UK, you will find information about reported PROMs and PREMs, and it's very transparent, and anyone can see this information. So. Now, obviously, this is not enough to tackle wasteful clinical care. You need a combination of different policy levers. Adherence to clinical guidelines and protocols can be encouraged by audits and feedback are really critical to tackle the different types of wasteful and particularly low-value care and adverse events. Behavior change campaigns have been shown to be effective. This is the case, for instance, the example of for antimicrobial resistance. There's been stewardship campaigns that have been shown to be successful. Hand washing initiatives also. And I want to mention in passing, in case some of you may not have heard about it, the Choosing Wisely campaign. Now, it hasn't exactly been shown yet to be effective, but this is a campaign which was initiated by the American Board of Internal Medicine, and has since been followed in different countries. And I particularly like the way the Italian have chosen to call it. They call it slow medicine. The idea is that it's a provider-led movement which really aims to tackle the problem of low-value care. And to do this, they do a number of things. They identify, they jointly identify types of care which may not be of high value, and they create information campaigns around this and tools to encourage a better dialogue between providers and patients. So you can look it up online. It's really interesting. And of course, financial incentives and nudge. Now, Australia's Queensland withholds payments for hospitals for never event. A never event is an adverse event that should really never have occurred, like taking out the wrong limb. And so they simply don't pay if something like this happens. But I'm not sure it encourages reporting. But there are different things that can be done, and disinvestment and really looking at the value, what you're going to be paying for as a country, as a public insurer is really one important instrument. There's been some discussions in the UK about reducing or removing some items from the list. But the one I find particularly interesting is Australia's benefit schedule review, which has been ongoing for a few years, and again the information is available. It's a really interesting approach, we think. Now, operational waste. Operational waste, I'm going to give you focus on the example of hospitals. Why hospitals? Because hospitals concentrate a lot of spending, and also because, well, to be honest, there's a lot of data on hospitals, perhaps more than in other parts of the system. But pharmaceutical is in another example we look at in the report. But if you think of operational waste and hospitals, well, there are people who end up in the hospital who shouldn't be there. There are inefficient processes within the hospitals, and there are also delayed discharges of patients. So 3 examples of these. One is probably know this, but there are a number of chronic conditions for which, it is generally considered that there shouldn't be hospitalizations. In fact, this is particularly if primary care is of good quality, hospitalizations should seldom occur. And so what we've done in this graph is looked at 5 of these chronic conditions, which include, diabetes, for instance, and look at the proportion of hospitalizations in EU and other European countries, the proportion of hospitalizations which are attributed or have for primary diagnostic these 5 conditions. So potentially, a good proportion of these, so you can see large variations in the rates. I mean, it goes from nearly 9% of hospitalizations in Bulgaria and Romania, with Croatia and Slovenia being below 4%. So there are wide variations, and 3.3 in Switzerland is the lowest. So there are large variations, and you can see that if these hospitalizations can be avoided, then clearly you could be or if these hospitalizations take care, you might be wasting money. Another example, the second example is within hospital. This is the development of day surgery, and it's been really uneven, even in OECD countries. I mean, you might think that this is a given, but it's not the case. I mean, we can look at Denmark and Finland. Denmark and Finland are considered really advanced when it comes to outpatient surgery. And Denmark, it's so for both countries, cataract surgery is almost always performed on an outpatient basis. But there you can see differences. I mean, when for tonsillectomies, for instance, in Denmark, it's just about half that are carried out on an outpatient basis, whereas Finland has reached more than 75%. And so even across these countries, there it really depends on the domain. But then if you look at Austria, cataract surgery is 85% on 85% of the time on an outpatient basis. Okay, but hernia repair 3%. Tonsillectomy and cholecystectomies below 1%. So a country like Austria clearly hasn't, made it a priority or has a lot to do to improve, the take up of this. Now, the last thing I wanted to look at was present set of numbers is about patients who are medically fit to be discharged, but stay in the hospitals. In England, they sometimes call them bed blockers, which is not really nice, but quite telling. We could only identify 3 countries that actually measure this systematically. You see in Denmark, so it has been decreasing steadily, and now it's stable. I mean, there might be inevitable minimum amount. England, the figures are staggeringly high, and this is a system where hospitals are really struggling to keep up with demand. And so if this could potentially be useful to address, and it has been increasing over time, and this increase actually corresponds to a period when spending for social care was decreased. So there are no alternatives. People don't stay in the hospital because they want to. They stay in the hospitals because they don't necessarily have an option. Norway, on the other hand, around 2012, introduced payments for municipalities if the people stayed in the hospital that shouldn't be there, and the hospitals, the municipalities then had to pay the cost. And lo and behold, incentives sometimes do seem to work. And this was not the only measure put in place, but it's an easy way to tell the story. Now, how do you, what levers do you use? And these are just obviously examples, because every single one of these, area requires specific policies. But basically, it's the same tools. Use payment and financial incentives. So tariffs to promote day surgery, for instance, in France and in Lithuania, you get the same price. For instance, you get the same price whether you perform, a surgery on a day basis, on an outpatient basis, and people figure it out. Now, Now, the problem is that if you kick people out of the hospital, you do day surgery, the concern is, of course, that they may have to be rehospitalized because they, it was too short. And this is the type of issues bundled payments are trying to address, where you really try to pay for an episode of care and to ensure that services are delivered in the right setting. Of course, if you want people to be treated in the right setting, it may be that the right setting doesn't exist. So you need to think, there are many policies around this. Out of hours care can be provided in many different ways. There is an OECD working paper on this. On-call physicians, a dedicated fleet. In France, in some cities, you have SOS médecins. They can come to your place if you call them. In Norway, they have larger health facilities where you can provide care at, extended out-of-hours care. Also community services, the rapid access clinics in the US. Other type of alternative services is hospital at home, which has been developed in France, for instance. But of course, this also requires that the providers and patients, be convinced and change their behavior. I mean, so of course you have the disease management protocols. I mean, you don't send a patient to the hospital to do this or that. So that will, that's of course part of the battery of things that you need to use. But you also need to have education campaign and to convince people that no, they don't need to go to the emergency room. If they simply have, or they need to be informed about what the alternatives are, and they need to believe that these actually going to receive the services. Now, last, I'm going to move to governance-related waste, and start with administrative costs. When you talk to ministers, and this was true during the crisis. What's the first thing you address is like administrative costs. We're going to cut the salaries. We're going to reduce administrative costs. Now, administrative costs, to the best of our understanding at the OECD, and we collect data, we spend a lot of time thinking about how to best collect data on health spending. They represent on average 3% of total health expenditure. And so we took a very close look at this there is a whole chapter dedicated to this in the report, and our impression at the end of the day is the differences in the level of administrative costs around systems are not necessarily a question of wasteful spending, and they seem to be largely driven by institutional features and the way you organize your health financing. So a multiple health payer system costs more than single payer system, and if you have private insurance, you're going to have much higher administrative costs. Now, I certainly don't want to open a debate about whether there might be some benefits that you get out of this, but the bottom line, I mean, from my line of argument here in this report is that this may not be as low a hanging fruit that you might think. Still, I mean, there are things that you can do if you want to tackle administrative costs and think about how to best manage administrative costs. There are two main ones: are functional reviews, where basically you decide or you make a list of what functions the government or the administration should be taking on, and review who is actually in charge and how to best organize this. Now, Australia did such an exercise: who is responsible for regulating this or for that, and then you can streamline. I know a country, mine, France, which could really benefit from this, where you have committees and so on, and commissions and institutions and institutes and so on. Now, if you go at a more micro level, you can actually, and this has been done successfully, for instance, in Germany or the Netherlands, is do multi-stakeholder review of processes. So you sit everybody around the table, everybody's complaining about the burden of administrative costs. You sit them around the table and you take, you list all the administrative processes that people find cumbersome, and you try to simplify them. I mean, you're asking me to report this information. Are you actually using them? No? Well, then let's maybe not make it a requirement that I report monthly. Or if you're going to look at it once a year, I may not have to report monthly. Or so this is really, it's much more micro, but it can actually, it's been shown to be helpful. And the last topic I'm going to talk about in this marathon is governance-related waste. Now, it was a bit, frankly, surprising to me when I looked at the data from Transparency International to find that about a third of citizens in the OECD countries, on average, believe that the health sector is corrupt or very corrupt. The global average is 45%. I have to say, I mean, I expected a larger gap between, you know, OECD and non-OECD countries. Now, the issue we faced when we started looking at this, I mean, there are many issues we faced. It's a very difficult topic on which not a lot is necessarily written, and perhaps not enough. People are not always keen about talking about fraud and corruption. In fact, when we sent a questionnaire to country about fraud and corruption in the context of the preparation of this report, and one country, and I'm not going to tell you which one it was, replied by saying, well, there's no fraud and corruption in our system, therefore we're not going to fill the questionnaire. So another issue we face is that there are a lot of terms which are used around fraud and corruption, abuse, and so on, and the terminology is not very standardized, and so we decided to, and if you use one term, people think you might be ignoring the other types of issues, so we decided to peg an umbrella term. We call this integrity violations, and this is meant to include everything. And again, you know, I confess to liking frameworks, but we try to organize, you know, what are we talking about? And we identified basically three main areas in which fraud and corruption is discussed in the health sector. The first one is really what happens between individuals, insurers, taxpayers, patients, us, the providers of medical goods and services, and payers, so doctors, hospitals, etc., and payers, public or private, insurers or the state, etc. And this is the first triangle. It's really integrity violations in health services delivery, payment, and coverage. And in this, you have a range of things from, you know, providers not showing up to work, or billing for services they haven't provided, requesting payments from patients, you know, pretending to meet the conditions to receive free insurance, or you know, paying providers in order to jump the queue, etc., etc. So this is all integrity violations in service delivery, payment, and coverage. That's the first bucket. The second one is integrity violations in procurement and distribution. So this is more between the payers, you know, public or private, the providers of medical services, and the suppliers. And this is really procurement. Now, we didn't spend too much time in the report looking into this. My take on this is that if you have a problem of corruption in public procurement, chances are, you know, you're going to have a similar problem when it comes to textbook for schools, and it's not necessarily hugely health specific. Now, there are specific issues when it comes to distribution and you know, fake the word eludes me right now, but drugs, you know, counterfeit drugs. But generally, this is not something we looked into in details. We tried to pay a little more attention to the third type of inappropriate or integrity violations, which we call inappropriate business practices. And these really occur between the payer, the regulator of the health sector in general, suppliers of medical drugs and medical equipment, and the providers of goods and services. Basically, it involves anyone for which the health market is a business. And to be honest, I mean, when you talk about this and you try to find the literature, it's generally the domain of activism. You very often find a very polarized discussion, virulent. And so what we try to do is we try to organize them in a way that would that would try to bridge the gap between the two sides of the stories, because of course the industry is outraged and so on. So we try to think in terms of, well, if you're a business, you have legitimate business objectives to promote a business-friendly regulatory environment, to gain a market entry, and to increase demand for your services and products. Marketing, I mean, if you're selling socks, there's nothing wrong about doing any of this. Now, in the health sector, the problems are, and other sectors, the problem, the problem is that you have to draw the line, and where you draw it is the problem, and you can really get inappropriate practices. So if you have, promoting a business-friendly environment and lobbying, then you fall into institutional corruption. If you want to gain market entry as an individual for your individual product, you can falsify data, and this is all the issue around manipulate or selectively present the information. We can talk about clinical trials, exerting undue influence on the decision maker. I mean, simply going with a suitcase full of goodies for the person who's supposed to make the decision about whether your drug should be on the market or not. But this is perhaps less subtle and less frequent in OECD countries. And then there are things that happen, to increase the demand of your product or services. And this could be done by individuals or individual companies or individual providers, and could start with, self-referral. Come to see me in my office tonight. You need this test. The insurance won't pay for it, but if you pay me privately, I'll do it for you. Promoting off-label use for a given medicine, or generally unethical detailing. But it can also be, so it can be done at the individual level, but it could also be done in a way, by groups of people to try to influence norms of collective decisions. So this is manipulating the demand for treatment by medicalizing health conditions, lobbying to lower intervention threshold or generally influence medical guidelines. And you don't necessarily need to do this yourself. You can also do it more indirectly. So you can work through key opinion leaders or patients association. If you fund patients association, then they might be sympathetic to hearing about this brand new drug that you have developed, or a brand new device that you have developed, and that would be just perfect for them. Now let's talk about, so we've presented these first two slides were really about again presenting the different types, and of course it's very difficult to obtain data on any of these issues. You'll be surprised to learn. But so when it comes to fraud in the delivery and financing of care, so first of all, I mean, for all the types of fraud and corruption, there's huge variations in the way countries discuss the problem and are open about the way they address the problem. The countries that do a lot when it comes to fraud in the delivery and financing of care, they typically have, their payers have dedicated and specialized departments. They typically do more than just having a hotline where you can report, if you're lucky, anonymously, some issues that you find, not being very ethical. But they actually do use very sophisticated data mining techniques to try to identify networks of providers that might be doing things wrong and so on. And then once you've identified the issue, I mean, they usually, usually what you have is you will find that there are issues for certain types of care. So let's say, dead prosthesis or medical transportation or this type of surgery, etc. And so what they do is they organize specific campaigns targeted at a specific, and they usually have a roster, this year I'm going to do 4 campaigns and it's going to be on ABC. The first thing they do is really try to engage the providers, because you don't want to be adversarial about this. What you want is really start, raising the issue with the providers. The providers themselves are probably not happy because it's not everybody that does it, and they'll be, that you need to engage them and have discussions about the quality of care and showing that you understand that there can be variations and you can have outliers. If you have, your patients is so special, you may need to do this, but, so you want to have a discussion about quality of care, and quality of quality of care and quality of coverage with the providers. But then you can do very simple things like sending a letter to the outlier saying, we're very interested in we've noticed that whereas, the physicians that have roughly the same patient profile as you do prescribe this in 10% of the cases, you prescribe it, 60% of the time. Could you please, tell us what this is about? And sometimes this is enough to just, put the problem, get the people to ask themselves whether what they're doing is really problematic or not, and change their behavior. So there are a whole series of things you can do, but what is really important, and that's been said to us by the people who work on this, is if you actually find fraud and corruption, you really need to prosecute to the full extent of the law, and this really has a very good deterrent effect. So you really need to be very public about what you found and what you're doing. Now, so this is, and there are a lot of good lessons to be learned, for instance, from the European Fraud and Corruption Network. You'll find the reference in the report should you be interested. It's a network of entities, payers that actually get together and try to discuss best practices in this, and they publish books quite regularly. So when it comes to inappropriate business practices, frankly, it's mostly, in most countries and most of the time, the domain of self-regulation. So you have codes of conduct, which are designed by the various industries or providers. I mean, the code of ethics, even for doctors and so on. Conflict of interest policies for universities, for instance, which are involved in clinical research and so on. There's, as far as I could see, and I couldn't find much information even on, do we know if there's a code of conduct for the industry? Do we know who actually adhere to it? Codes of conduct typically have say that if there is a problem, if the industry finds a problem, they'll deal with it. There's no data about, how often does this happen? Does it ever happen? So I think this is a place where a lot of research could be done. I mean, there's increasing regulation. Some practices are being regulated. I think it's a bit of a whack-a-mole game. So if there is a big scandal, then there will probably be a regulation put in place. The only exception we could find is sunshine type of regulation, which mandate the disclosure of financial ties for providers and industries, various industries. The US was the first one, I think, but France also has such regulation, and a number of countries, including, I mean, some codes of conduct. Interestingly, the European Pharmaceutical Code of Conduct is much more strict when it comes to disclosing relations than some regulations of the European countries. Now, I've come to the concluding slides of this presentation. So when it comes to tackling wasteful spending, I mean, if you're a policymakers and you're asking yourself, where should I start? I mean, I think reducing wasteful clinical care could release a significant amount of resources, but you really need to think that the patient and healthcare providers must be on board. If it's a top-down initiative, it's probably not gonna work. Administrative waste or loss to fraud and corruption is present in all systems, and it clearly shouldn't be tolerated. But at the end of the day, it's important to realize that the magnitude of the potential savings is relatively modest, because even if you cut 20% of 3% of total health expenditure, this is not where you're going to have to find fiscal space, to deliver more and better care. Eliminating operational waste is more complex. There's not a whole lot of evidence about policies that work, but I think it's interesting because if you have discussions about wasteful spending and how to reduce it, let's say the hospital care, inappropriate hospital care. If you reduce, the time people spend in the hospital, then it might help paved the way for reforms like the restructuring of hospital systems, which is still required in many countries, especially in Western, well, in Eastern Europe. So if you get people out of the hospital, then it might be easier to discuss the restructuring and reducing the number of hospital beds. The second, it's about the levers. I mean, the first thing you need to do is to recognize that the problem exists. I'm going to tell you, and the example I gave about corruption was a telling one. You need to talk about the issue, and then you need to inform. You need to strengthen information systems, generate and publicize indicators on waste more systematically. I mean, in many cases we found one country that had something interesting and another one, but it's really not all information systems can do the stuff that would be really useful. You need to leverage incentives. But I think, I mean, for me, the key lesson at the end of this report was the importance of persuasion. So you really need to think about, the bottom line is behavioral economics. You really need to make sure that the people whose behavior are expected to change are actually incentivized to do, not financially incentivized to do so, but understand or see that it is in their interest to do so, and motivated to do so, because you're not going to get anywhere if you don't do that. So the lessons we've learned from the report. I mean, I really think the report has opened discussion, and in many countries and at all levels. I mean, I'm going to give you an anecdote to conclude, because when I started this report, I was told, okay, you need to find a title for this report, but whatever you do, don't put the word waste on it. And after I worked for over a year, and at the end, I came up with a very convoluted title about opportunities for saving resources or something like this. And my boss came back to me and said, well, why don't you call it wasteful spending on health? I'm like, well, because you told me not to, but that's good. We've made progress. The other thing that we found interesting is that using waste as a point of entry in discussions, in policy discussions, is much, much better than efficiency. I mean, when you start with the word efficiency, first of all, most people's eyes, glaze over and they sigh, because they see, when you talk about efficiency, it's basically a code word for budget cuts. And when you talk about waste, it's not so obvious, or it's not what you're talking about, and it really gets a foot into the door. And we've talked about waste with patients association, providers association, pharmaceutical companies, governments, academics, countries, you name it, different countries. It really opens the discussion. So that's really useful if your job is to involve policy dialogue. But you also have to recognize that this only gets you this much farther, because someone's waste is somebody else's income at the end of the day. So you will have to face the same tough difficult decisions. And I want to be clear that don't want to go into a discussion about the gender of angels, but waste and efficiency are not exactly the same thing, and waste really doesn't cover all efficiency, in particular when it comes to big issues of allocative efficiency. A discussion about waste is not enough. So if you want to say, okay, we need to invest more in curbing risk factors and investing more in public health, this is waste is not necessarily gonna get you there. The last point, and promise this is the end of it. Waste is not just a problem of rich, for the rich. The waste agenda is also very relevant in low and middle income countries. In fact, if you want to be convinced, you can take a look at the Lancet series on low value care, and they took examples for around the world. But this is just one example of waste, but it's a good place to start. So this is it. This is the cover of the report. You can find it online at the OECD. We also there's a chapter in Health at a Glance Europe 2018 on waste in hospitals and pharmaceuticals more specifically, and more recent. And you can reach me at, and I gave you a wrong address, so it's not a.couffinhal@worldbank.org, but a.couffinhal, forget the dot. And you can reach me if you have any questions, but of course I'm ready to take some now. And thank you.
Agnès, thanks. Can you hear me?
I can.
Okay, so there are 3 questions, one from Martin and 2 from Jack. Now, okay. Martin, I have forwarded those questions to you. Could you find it?
Me? No, I haven't been able to find the, oh yeah, the chat, sorry.
Yeah.
Oh yes, chat. Inappropriate admissions to facility. Is that Jack Langenbrunner? Okay, so inappropriate admissions to facilities. So yes, I mean there is data on the report. As I said, I mean for emergency inappropriate admissions, I mean they're inappropriate admissions that are for procedures, you know, that are maybe not necessary. So you could argue, you know, if you do a C-section that is not necessary, then you have an inappropriate admission for it. So yes, it's you know, if the, you know, I'm sure they also exist. I mean, 50% in China. I'm not surprised. I'm not surprised to see. But yes, there is OECD evidence. Guidelines and protocols. I mean, do they save money? It's not about saving money. It's about it's really about making sure that the care you deliver has value. So if you deliver care that has no value, you're certainly wasting money. So the more you deliver care that has value, the less presumably you would be delivering care that has less value. Discourage and encourage all washes out. Well, you know, that's so let me see if I have question on me. So somebody asked me if the different types of waste differed between different types of health systems. Let me think about that one. I think that there's probably a case to be made that in systems where everybody is paid on a fee-for-service basis, and a case-based payment, there are more chances that care of lower value could be more frequently provided. You know, it's impossible to prove. I mean, I haven't, you know, or maybe, I mean, it could be done. This would be an interesting question for research. But at the same time, you know, the question of low value care is also very important in the NHS. It's discussed in the NHS. I mean, there is a paper by, I'm going to say Mosialos, but I'm not 100% sure, that looked at low value surgeries in the NHS. So I would say that systems that have you know, those are the kinds of intuitions that we get from the reports. Like there's certainly more of this in systems of payment for fee-for-service, but then you would have to go through the different types. You know, if you have a system with better primary care, then you might have fewer. And I think the OECD has looked at this in a more recent working paper on if you have better social care. And the example of the UK was quite striking on the number of days that people spend in the hospital where they don't need, or what Norway introduces. Like if you have better social care, then the instances of of people spending more time in the hospital simply because they have no place else to go might be reduced. So yes, you would find patterns, but I'm not sure I think they have more to do with the way each segment of the system is organized than overall messages that you can give about this type of system or that type of system. Thank you. And let me see, sorry, I'm going through state of health, could be called adverse event following an intervention. How do we handle that? Because we elicit events from clients and households. Well, the OECD, I'm not sure I understand the question, but the OECD doesn't elicit, I mean, at this point, adverse events, reports of adverse events from patients. I mean, these are reported by the hospitals themselves and the providers themselves. Do you think we can find between the two?
You can forget this one because you already make a response.
Okay. The US has one official of fraud where whistleblowers protected from it gets a percentage. So I haven't seen. So sorry. The question was you don't necessarily have access to the question. There is a policy whereby in the US whistleblowers get a percentage of the amount that they've helped save. I haven't seen it anywhere else. I'm not saying it doesn't exist. I'm saying nobody reported doing this except the US. So the US, I mean, they were very interesting, if only, piecemeal things that were done on fraud and corruption. I mean, I think that, I look carefully at what Medicaid, Medicare does, and it's really, I mean, there are a lot of interesting things that are being done, and every year there is a report which is produced, etc. It's one of the countries where you can actually have data about how much is recovered, etc. Another interesting initiative I found was in the US as well. There is an NGO which looks at how much money is being paid by which industry, and the health industry is an industry which pays a lot of money to the people who then, and how they vote. I think I remember that. And there was another initiative where they were looking at all the lawsuits every year that take place against the pharma industry to try to see, to shed some light into this. So I've seen NGOs do a lot of good work on this, but when it comes to institutional fraud and corruption in the US, but I've seen very little in other countries, and this is an area I think we could do a lot more on.
Okay, if any more questions are not there, thank you very much for all the participants. And
so, sorry, there was one last question about the logistics, the wastage within the logistics system. So in the report, we do so we looked at waste in the context of pharmaceuticals. There is a section on this. We didn't find a whole lot of data. There is actually, there's some interesting initiatives in the UK, for instance, to try to measure how much is wasted on prescriptions that are actually filled, but the drugs are never used. But there's also some data we put there, whatever data we could find on logistics, waste in logistics system, but it wasn't, we couldn't find that much data, to be honest. Okay, maybe I'll stop here because I see that there might be new messages. But I want to thank everyone for listening in and either waking up early or staying up late. And I thank you all.
Thank you, Agnès, for a wonderful insight. And thank you all the participants for enjoying Agnès' session with us. Hope to see you soon in our next webinar, and look forward to your active participation in the activities what EFFSIG is standing for. Thank you again.
Thank you and goodbye.
Bye-bye.